said, please keep your mics off if you're not speaking. If you can, leave your video on, that would be great. We like to see your faces. Put up your hand if you have a question. And there will be times when we will ask you also to share, and then you can activate your mic. So for today, we have quite a full program. We're going to be having a presentation and a welcome by Tebello. I think everyone knows Tebello. She's a palliative care nurse who's working in the UK, and she's also started the a hospice in the UK. She's the founder and the COA of the Starlight Oasis of Hope Hospice. We will be also then having a presentation on the introduction of palliative care by Joan Marston. Joan Marston has a lot of experience. She's a nurse from Bloemfontein. She's got 34 years of palliative care experience, national, international. She specializes in palliative care for children. She's part of PallCHASE, Sunflowers Children's Hospice, and the Elizabeth Kubler-Ross Foundation. And then we may have a presentation on the ECHO model by Dr. Leonard Bikinsi if he shows up. We will have another question and answer in large time at the end, and we will try to be finished by 8:30. So just a warm welcome to everybody. And please know that we will be very interested in hearing from you and learning from you and your experiences. So Tebello, I'll pass it on to you. Tebello, are you there? I'm not sure if she's having problems with her connection. I know that Tebello is very passionate and very informed about this situation in Lesotho. I think you will all appreciate hearing from her. I think as I get to know Tebello, one thing that I would say is that her passion for palliative care is infectious. And so I know that if you hang in with us during this course, you will be changed, and you will also share some of the passion for palliative care. So now it looks like Tebello, you're with us, right?
Yep.
We can't hear you though.
There we are.
Tebello, we can see your slides, but we can't hear you.
Any better now?
Okay, now I hear you.
Yeah, we can hear you. Thanks to that.
Okay. And good evening, good morning, or good afternoon and good night in India. So we are very, very grateful for this moment in time. And as I've been mentioned, my name is Tebello Malichaba Lepheane, and I'm a registered nurse with a palliative care expertise, working and living here in the United Kingdom, where I have worked tirelessly with our team to set up Starlight Oasis of Hope Hospice as a charity that is aimed at providing care in the Kingdom of Lesotho. And the aim for today is just, as my colleague Esther has mentioned, we have been able to complete batch 1, and now this is batch 2, which we are hoping to work together, exchange knowledge, and see how best we can change and improve the quality of care we deliver to the patients and their families, those affected by serious illnesses like cancer. And I would like to take this opportunity as well to thank all our participants who have been with us in batch 1 and still committed to continue with us in this batch. Grateful to all our partners PallCHASE that have been working behind the scenes to make everything possible. Our colleague Erin, who is not being able to join us today as she is traveling to join another conference in another part of the world. our project ECO team, we have got our colleague who is the Sangam representing project ECO in India. And it is quite late at night, but she's committed to support this program. Our umbrella body, APCA, which is very much dedicated in supporting and ensuring that palliative care provision across 54 countries of Africa is of good standard and people are really given the quality of care they deserve. We have got our partners for Palliative Care Works as well that are here with us. I guess Dr. George will be joining us if he hasn't joined already. And our Ministry of Health for actually being our partner, and also our mother and parent as we are operating under their care and support. We thank everybody, our participant, for committing time for this 8 weeks. The whole reason is just, we just want to know you, as my colleague Esther mentioned, if we can rename and ensure that the names appear as we registered, so that when we issue out the certificates, they will be appropriately issued. So we have got this team of colleagues. Many of them will be joining us and have already joined tonight. Some, because of other commitments, might not be able to join us today. But we have got this support from over 12 countries of our colleagues in different parts of the world, and we are grateful. So just to acknowledge that the material that we are sharing, mostly it's been prepared by our PallCHASE and two World's Cancer Collaboration colleagues. And we are grateful for all the foundational work they did. And as I mentioned, we are under the support and the license of APCA for us to be using this project ECO through PallCHASE. So the session is mostly to give us an overview of the history of palliative care in the Kingdom of Lesotho and explain variety of partners and NGOs, as well as individuals that have been playing part and supporting the palliative care development in the Kingdom of Lesotho, as well as just giving ourselves, and you might even know better than myself, the situation on the ground in terms of the palliative care needs of those with life-limiting conditions. So Starlight Oasis of Hope Hospice, and as a charity registered here in UK, also registered in the Kingdom of Lesotho, we had the privilege of being supported by Her Majesty Queen as our patron. As many of you might have seen, last year we launched the program officially at the Royal Palace, just to announce to the public, also to commit that we're determined to really try and bridge the gap, working with all those involved in the health and social space. So this is Dr. Paul, who has been working day and night, was setting up Starlight and ensuring that he established all the governance and everything involved. He is our chairman. He's a retired GP, very much committed and very passionate with mental health and palliative care. And unfortunately, today he has not been with us, but he has really wanted to pass his regards, and we just will as we continue. So he has been honestly the person that I say, if he wasn't part of this journey, I don't think Starlight would be where it is today. So I'm grateful to him. Myself, most of you would know me as my colleagues, whether we work together or we train together. Or probably just starting to know about me. This is my family when I'm not really engaged with Starlight and other businesses. This is where I spend my time and the people I share my life with, and definitely they were the first one to capture this vision and believe in it and encourage me daily, and I'm grateful to them all. Otherwise, I think it is a wonderful thing to always remember that any kingdom has got a king, and every kingdom has got a constitution under which we know His Majesty King has had this words which are always really resonates with what we are trying to establish as we work with all partners across the world and colleagues back in Lesotho. He said in his clarion call, let Vision 2020 be a band which binds us together and which strengthens our oneness and catalyst that space us on the higher level of performance and achievement. And I believe that does not pertain only to the people that live in the country, and hence why as Mosotho living abroad, still felt like even though I have got the privileges of what my dear lovely United Kingdom offers and continue to be of great home for me since the past 18 to 19 years, but at the end of the day, it is always an incredible thing and an honorable thing to really try and do something to help those who might not be in the same privilege as I am. And that is why we are committed as Starlight to try and work with everyone to make a change. In Lesotho, there's been some work done by the team that Joan Marston is part of, ICPCN, working together with APCA back in 2017, whereby they trained about 30 people in Lesotho, trying to see how best the knowledge could be decentralized. It was mostly around the children palliative care, as ICPCN stands for International Children Palliative Care Network. And some pharmacists were also trained in Bloemfontein in terms of how to reconstitute morphine or even mix the chemo stuff. So we have had this privilege of support across the border, and some of the people even went to Majon's hospice for the placements, like people from the National University of Lesotho. But sadly, this program didn't progress much. And the documents are there, but the implementation has not really been countrywide. The last time I knew, there were some pilots in some districts, but we believe now onwards, we are to work together and get more ambassadors in different areas and spheres as doctors, nurses, pharmacists, and educators, all of us and social workers, to see how best we can really push forward. The situation at the moment in Lesotho is that we still got a work to do for finalizing our national cancer control policy. It's been in the draft form since 2019. Then 2020, we touched on it as part of the technical working group, but it has not been finalized as yet. So we are still working together with those individuals involved to see that as a country, we have got the up-to-date control policy. Again, cancer and other life-limiting conditions, which are mostly within the arena of non-communicable diseases, we still need to update the strategic plan as well. So as Sankatana Oncology Clinic, our only clinic within the kingdom, it is establishing palliative care services in every way possible, but their capacity is limited by the funds, because the funder that has been supporting them for the past 3 years, that funding has come to an end. So these are the challenges as well as the successes, because something has been done. It's just to continue the momentum and raise awareness of the need for the budget to cover these positions and ensure the continuity of service that will be piloted and actually be distributed across the kingdom. As well as chemotherapy is now being given at Sankatana with some of the patients who do not need other additional issues, treatments like radiotherapy. So in terms of what we are actually looking at as we push for this education and training in Lesotho, it's because as Starlight, we are guided by the 4 operational pillars of advocacy, education and training, care and support and treatment. But we have aligned our guided pillars on what the World Health Organization has called as a public health strategy for palliative care, whereby at the center of it is about the people who have got the needs, because indeed there has to be nothing that is done about them without them. So we have to identify their needs and ensure that the patients and are at the center of all that we do. Ensure they have got essential medications, especially morphine and other related medications that alleviate their suffering and symptom burden, as well as ensuring that education and training is an ongoing thing, whether as an in-service or as a formal education as in the institutions at the undergraduate or even when we progress to postgraduate level. Research being the foundation of all that informs the palliative care provision, and health policies, as I mentioned, and empower people and communities, because many of the patients have got no clue that there's a medication called morphine, which can definitely make their life better, those that are experiencing 24 hours of pain challenges. So that is where we are. There are so many opportunities for improvement. Like I mentioned, morphine issues, we need to address that, improve for the guidelines and policies, and ensure that as a country, the quota for the country is increased to allow adequate doses of morphine in each and every health center or district hospital, so that somebody from Smongong, where I come from, or even Mokhotlong, doesn't have to really endure expensive long journeys to come to Sankatana for a couple of doses. So the policies and guidelines is our next big challenge. Social challenges, it is all about making sure that ministries that are relevant to patients' care and support, like our own Minister of Health and Social Development, they collaborate and ensure that the needs of this patient are really dealt with in a good way. And as we are aware, many years back, 2012, when Social Development became independent of our Minister of Health, we lost the clinical social workers within the healthcare facilities. That left a big gap, because the patients' cases are picked up in a bigger caseload that includes everybody else from the villages, instead of the social worker being able to be directly involved in the patient's care as part of the multidisciplinary team within hospitals. We have got all these issues to address, palliative care in the existing healthcare programs, as well as in academia, ensuring that palliative care is allocated a distinct budget within the national health budget to ensure that it is actually covered and catered for. So to continue with the palliative and hospice initiatives, we are very grateful with Najojo as well in the Berea district under the care of Dr. Tony, because they are doing some help in those villages within their reach, but we still need to increase capacity. Palliative care services in Lesotho has just been a clear collaboration of all the partnership from all directions. As I mentioned at the Sankatana, there is also a palliative care team that has been set up, which needs more support. Najojo, as I mentioned, that is the team of Dr. Tony and his colleagues. As Starlight Oasis of Hope Hospice, our land is at Makaka. We are just preparing to try and set up the building very soon so that we can start being on the ground, not just support patients over WhatsApp or calls or only when we are in Lesotho. And we have got our, as I mentioned, in South Africa, Bloemfontein, as we know that our patients are all heading to Bloemfontein for their challenges with a complex medical conditions, including cancer. And we have got the team of doctors in those two hospitals, including Joan with the Children's Hospice, that are supporting our patients' journeys, and many other stakeholders, including those organizations in our communities that are supporting people with cancer. Organization, we are looking into how best we can collaborate, work together, and ensure that we address all these issues under one umbrella, so that we have a uniform way that will be standardized in order to ensure, as we now develop palliative care across the country, that we are adhering to the international guidelines and guidances. So we have to work together, and there's this code that I like, that if you want to go fast, go alone, but if you want to go far, you have to go together and work with others. So we are in the process of registering this association. But again, we also realize that many people across the hidden pockets of our Lesotho as a mountainous kingdom will have trouble to really travel long distances to make their needs known. So we have developed this Starlight application, which will soon be launched and for everyone to download, so that anyone with a palliative care challenges can refer a patient, whether it is a healthcare professional or for any form, or the patient themselves or their next of kin. So we are in the process of finalizing the linkage with other government ministries to ensure that we really capture the information appropriately. So this is where our base is in Berea. That is Dr. Paul. We were there in November last year, and we had the privilege of meeting the chief and the local councillor there, as they are the people that were behind really that land and ensuring that we get the grace from the community to really give us the land. And we are grateful for that support, and we hope to really erect this plan, which I'm hoping Mayor Musunyana, who was gracious enough with her team, has developed this plan as a charitable work, donating her skills and expertise to support our movement. And I'm hoping she was finally able to join, because she had technical issues, I noticed. And we are grateful. So it has been a journey indeed from 2017, when I brought this vision out to the public, which I really struggled to really get on with it, because I was really terrified with the magnitude and how overwhelming it was. And at the time, even my children were younger. That was 2010, and I was really confused as to how can I be of any service or help to Lesotho when my family is just getting started here in UK and my children are still going to school. So by the grace of God, by 2017, I was confident enough and bolder in my faith and confidence in the one that provides, that he can make all possible. And indeed, I'm grateful with everyone that has been working this journey with us. And here it was, I think, 2019 when I visited a couple of patients. And by the way, this picture was shared with a patient's concern. But sadly enough, for the lady that I'm sitting next to, she's now passed on. She was from Lesotho, and she had a advanced disease with cancer. And soon after this visit, I think a month after, she passed on. And what has really been engineering and pushing my determination to push and work with everyone to make Starlight something that will be accessible for Basotho is out of the compassion, out of the caring heart, out of all that we can share as humanity, because each one of us has been made to be of service to another, to be a blessing to each one of us. And indeed, it is all about being the brother's keeper. And I guess that this is the sole reason why we are all gathered here, because we are all determined to make a change. And in terms of closing now, really thank you very much. And I would like to tap into this wonderful quotes, which John Wesley, the father of Methodist Church, said this wonderful words, which always speaks deeply into my soul, even when I get a bit exhausted trying to push the barriers to make a palliative care advance in Lesotho. But I always come back to these words to encourage me. Do all the good you can by all the means you can, in all the ways you can, in all the places you can, at all the times you can, to all the people you can, as long as ever you can. And I believe that is the case for most of us, for we believe we are here to serve. And if we are here to serve, there's definitely that whisper in each one of us hearts that really show us the way, that inspire us to serve, that really motivate us to do more than just the ordinary title that we have been given at our different workplaces. And that voice is the one that when you have heard from it, there's no way that you can forget what that voice has spoken to you. You can hear my voice as I have been talking, but you are likely to forget my voice. And I pray and believe that the voice that will come through me and that will speak into yourself, into your inner being, will be the one that will bring about it, the transformation and the inspiration and the motivation to do more than just what we normally do, to try and answer to the needs of the children, the youth, the men and women, and everyone that is facing the challenges around life-limiting conditions. Our country is facing a rising burden of cancer, as we are all aware. And these issues around whether it is kidney disease, it is on the rise as well. And people are suffering, they are in pain. They need to be spoken to with compassion and understanding. And they need us to express empathy as we share their journey and walk with them, to involve their families and everyone concerned, to refer them and escalate their issues appropriately, and to work as a team to ensure that we collaborate and we actually ensure their complex issues are shared and that they are acted promptly. And I guess with this, I have come to the end of this presentation, and these are a couple of references. And I would like to thank you. For anyone that might want to get in touch other than the WhatsApp that you are aware of, then that is our website where we have shared our vision for Lesotho, and that is our email. Thank you very much indeed, Esther. Thank you.
Thank you, Tebello. We have a few minutes before we start our presentation from Joan. So I'm just wondering if there's anybody, any participant that has a question for Tebello or has a comment. You can just unmute put your hand up and then unmute your audio. Anybody? Tebello, before when you were trying to figure out your voice, I was just sharing that you're actually quite infectious. Your passion is quite infectious. And so I know that we will all be touched again by your work. Thank you so much. Your empathy, compassion, your commitment. I think that each one of us can make a change. I think when we look at the whole issue, it's overwhelming, but as we work together and we have faith, each one of us can make a change. And I think it encourages me to know that that was 2017 and now we're 6 years later. And so we need to be patient as well. I know I'm one who gets really frustrated if I don't see change right away. And so I appreciate that perseverance that you have as well. So maybe we'll just move to you then, Joan, because I think you're probably ready for the introduction of palliative care.
Yes, thank you, Esther. I'm just seeing if I can share screen. Would you give me permission to share the screen, please, Tebello?
Thank you.
No, not yet. Oh, there we go.
Let me, yeah.
Let's see. Oh, there we go. Can everybody see that and everyone hear me? It's really good to be here with you this evening. And thank you, Tebello. It's so wonderful to hear your story. And I can never get enough of it because the passion that we share for palliative care, Esther, as you said, it is infectious. And I hope it's going to infect each and every one of you who is here today. And so I come from Bloemfontein, so I'm almost a neighbor. Many years ago, I worked in QE2 hospital, training nurses and working for the nursing council as well. And I've had a long partnership with people from Lesotho, training, going, visiting, and having done the pediatric palliative care training, as Tebello spoke to you. I'm not going to go over this because Tebello has already shared it with you. But what I'm going to try to do today is basically give you a framework about what palliative care is. Because over the next 7 weeks, you're going to be getting special sessions on different aspects and elements of palliative care. You're going to be getting reading to go through, videos to look at. And so there's going to be a great learning on the detail. So today we're going to look at the framework because everything needs to be within a framework. So basically looking at an understanding of palliative care, something from the World Health Organization, their key facts, the goals and the scope. If we have time, we'll go through the trajectories of dying and we can look at a couple of models. But actually what we really want to look at is what is going to work for Lesotho. Because you can have all these amazing models in different parts of the world, but the context is so important. So palliative care, it developed from the hospice movement. And when Dr. Balfour Mount realized that to talk about hospice in Canada, in French-speaking Canada, would actually give the wrong impression when he wanted to take it into the hospital where he worked, he looked for another term. And he settled on palliative care. And palliative comes from the Latin pallium, which means a cloak. It is something that protects you from the elements, just like the beautiful blankets that you wear in Lesotho. It protects you, but it doesn't take it away. The cold is still there. And so the term palliative care means an extra layer, protection, comfort, and it's comfort when usually there is no cure. So of course, the World Health Organization from 1998, they started with their definition, and it actually has quite a lot of content. So we're just going to look at the basics here. And they say palliative care is an approach. And because it's an approach, it is something we can use when we are dealing with patients at all different settings and at all different levels of needing palliative care. And it improves the quality of life. So quality of life is a very important concept in palliative care of both the patient and their families, because we see the patient and the family as the unit of care when they are facing the problems that are associated with life-threatening and life-limiting illnesses that can continue over a long period of time or might just cover a short period. And it's about relieving suffering, preventing and relieving suffering, identifying the symptoms and the condition very early on, doing impeccable assessments. So it really challenges us to improve our assessment skills. And because it's holistic, it looks at the treatment of all problems that the patient and the family are facing, whether they are clinical, physical, psychological, social, and spiritual. So we are looking at the patient as a whole person, not just as a diagnosis. And these are just some pictures from other African countries showing you how it can be provided in the home, how often our teams have to go into very difficult areas when you're providing home care. And you might get just so far with a 4x4 or a big vehicle, and you walk the rest of the way. And then, of course, the issues of managing the medication, and in some countries, manufacturing the medication as well. And of course, we can never forget the children. So when we talk about the children, we are actually looking at principles that remain the same. It is about the active total care. So active is important. It's about how we apply what we know. It's the total care again of the child, remembering they, no matter how small they consist of a body, mind, and spirit, and especially giving support to the family. And to remember that palliative care, the best place for it to begin is when the illness is diagnosed, and it continues whether or not the child receives treatment directed at the disease that may control or in fact cure the disease as well. So it can be given alongside chemotherapy, radiotherapy, antiretroviral therapy, any kind of therapy that controls and perhaps even cures a disease. But it is the child that makes the difference. Sorry. Because we are looking at palliative care, sometimes from before birth, when a child is diagnosed in utero with a life-threatening or life-limiting condition, and we start to prepare the family, especially the parents. And it continues after death, because we go on, and after the patient has died, we continue to provide some form of bereavement support for the family and those that are close to the patient. It goes across all ages, from before birth until vast old age, and it can be provided in all settings where our patients live. So whether that's a home, a hospital, a clinic, a home for older persons or children, in inpatient units, in a prison, and there's some wonderful programs taking part in prisons, and even for the homeless on the streets. And symptom management, we can manage pain and symptoms very well at home, provided there are some resources and people who understand how to take the medications, how to assess, and how to report. And so we can see with medical care, it shifts from where we normally try to cure the patient to focusing on a good quality of life through relieving suffering, until we go to optimizing comfort at the end of life. And this is a very simplistic model because it looks as though things go in straight lines. And we know, of course, that things don't go in straight lines. But even when we're screening the patient who's feeling anxious about their symptoms, we can bring in our communication skills from palliative care to support them, to explain to them what is happening. Then a diagnosis is when we really should start with palliative care. The resources are limited, though we often find it only comes in very near the end. But the ideal is that it goes alongside potentially curative care. And as curative care is found to no longer be effective, palliative care increases and becomes the major form of care. And then, of course, around the time of dying, end-of-life care, there's very specialized and intense care that happens. And as I've said, we go into the bereavement period as well. And the WHO recommends that beginning palliative care when a patient is diagnosed with a life-threatening condition is the ideal. Also recognizing if you haven't got the people who can provide it and the resources, the chances of it starting there are slight, except if all our doctors and nurses are trained in the principles of palliative care. That is when the palliative approach can begin. And for some patients, in fact, when there is no cure from the time of diagnosis, palliative care may be the only form of care that is provided, where curative options are not available or will not be successful, with very late diagnosis, which we see so often. And then, of course, with some conditions that are genetic, identified in the perinatal period, congenital conditions, where we can comfort the patient. They might live for many years, but the care that we provide is predominantly palliative. And this actually really encompasses what it's about. And this is probably the most famous quote from Cicely Saunders, who is known as the founder of the modern hospice and palliative care movement. She began as a nurse. When she hurt her back, she went on and qualified as a social worker. When she was told doctors won't listen to you unless you become a doctor, she became a doctor. And in her own life, she was a committed Christian. So she was a multidisciplinary team in one person. And she said, you matter because you are you, and you matter until the last moment of your life. We will do everything in our power to help you achieve a peaceful death and to live until you die. So we're not the death and dying squad, we're the life and living squad. And she was the one who brought the term total pain to our attention. She said, when someone has the serious condition, the pain they experience is not just the body, it is in the mind, in the emotions, it is a spiritual pain, and it affects the social environment in which they are. And you will hear more about that in another presentation, but it is a core concept of palliative care. And because our care is holistic, it requires a multidisciplinary team. And that team can be those that we have available, but it can also be according to the patient's needs as well. So with children, we might bring in a teacher, a play therapist, a psychologist with special skills with children. And the members of the team that are so important are the patient and the family, because we take decisions, including ethical decisions, with the patient and the family, not for the patient and family. A lot of discussion goes on. And with children, we always need to remember we have to act in the best interest of the child. And that overrules any authority of families and parents as well. So we need to remember that. So the child, the family is always a member of the team when we come to decision making. And this is Professor Liz Molyneux, who ran a wonderful program in Malawi. And her mantra was always, do things simply and do them well. And I think it's something we could all remember. So the goal of palliative care is the prevention and the relief of serious health-related suffering and the improvement of quality of life. Those two concepts are absolutely core. But the principles are that we see death as natural. We're all going to die, whether we like to think about it or not. It's going to happen. It's a personal process. We experience it ourselves, and it's a natural process. We have spoken about how important it is to get in there as early as possible, and we need to respect the patient and the family's preferences, their culture and beliefs, because we care for this patient within the context of their own life, of the society, the community, and the country in which they live, and within their belief system. And as we've said, it can be combined with potentially curative therapy. We've talked about relief of pain, but of course of other distressing symptoms that go along with these conditions as well. And we neither hasten nor postpone death. So we don't go along with euthanasia, nor do we try to extend the death and the suffering. We try to let death take its natural course and support the patient along the way. And the psychological, the emotional, and the spiritual aspects of patient care, which we can all provide on a different level of skills to a psychologist, a social worker, but we all can provide that, are so important, as is cultural respect. And I think if I was to say one thing is the most important that we have to learn in palliative care is competence in communication. Communication skills are really core to everything that we do, from assessment through to treatment, through to psychosocial, spiritual support and bereavement care. And in fact, Balfour Mount, who initiated the term palliative care, said, after we control the pain and the symptoms, our most important function or role is to facilitate the discovery of meaning, which is spiritual care. And of course, we try to restore dignity, because this is something patients often say, I'm losing my dignity. And Balfour again said, the hospice movement has done something dramatic to medicine in that it is putting the patients back at the center of care and regarding them as whole people. And Dr. Harvey Chochinov, again a Canadian, he really developed the field of dignity therapy. And he said, we need to ask each patient this dignity question. What do I, as a clinician, social worker, nurse, need to know about you as a person to give you the best care possible? Again, bringing the person into the care that we give. We know from some research, palliative care can extend life. It reduces unnecessary hospital admissions. It reduces costs. Beautiful research coming out of Malawi and the use of the health services. And it provides a support system to help the patient live as actively as possible until death. When we have the teams in place, this is the result of palliative care. So who can provide it? We can all provide it. Whether we use a palliative approach, whether we have more knowledge and skills to provide general palliative care, or whether we go to UCT or to Uganda or overseas to the University of Cardiff or Malawi to study and specialize in palliative care, where we gain those extra skills, we can all provide a level of palliative care. So what do we need to provide palliative care? Well, I'm not going to go over this because Tebello actually explained with that lovely diagram of the house. But there is one extra thing, and it's something that I think Tebello has in abundance. And this is said by Dr. Anne Merriman. She said, to provide palliative care, you need fire in the belly. We need to be passionate. We need to be enthusiastic. And Anne is deep in her 80s, and she is still active in the field of palliative care, one of the great pioneers of palliative care and strong advocacy. And I would encourage you to read what Tebello wrote in e-Hospice, where she talks about the approaches to be ambitious but realistic, bold but sensitive, stress palliative care. It's not necessarily a specialist area, and we should all have basic palliative care skills. Much care can be delivered at home, and it can ease the psychological, physical, social, spiritual, and the economic burden on families. So it's really great to have someone with fire in their bellies who's leading this. So how many people need it? Well, each year, nearly 58 million people are in need of palliative care. 76% of them live in low and middle income countries, but only 14% of people who need palliative care currently receive it. And so that is a great challenge to all of us to do more as long as we can, to follow the quote that came from John Wesley. We need the policies, the programs, the resources, and the training, and we need the systems to provide it as well. When it comes to the need among children, more than 97% of children who need palliative care are in low and middle income countries, and 52% of these children are in Africa. Yet in the whole of Africa, only 3% of the people who need palliative care are presently receiving it, according to the Global Atlas of Palliative Care. 3%, that is very low. So after this course, we know that there's going to be a rise in those figures. And it's going to continue. We have aging populations. We have an increased burden of non-communicable diseases. We have an increased incidence of humanitarian crises, of climate crises, of war and unrest. So this map just shows us a little bit about development in all countries. And in general, it is in the higher resource countries where palliative care is best developed. So the UK, Europe, North America, and then places like Australia and New Zealand, and of course across Europe. But even in very poor countries, we see some good palliative care. So in Africa, the most integrated palliative care systems are in Malawi and Eswatini. So that is encouraging to you in Lesotho in how you could integrate palliative care into your health systems. I spoke about humanitarian situations, which is what PallCHASE is all about. And we need to remember, while the primary object when a humanitarian crisis starts is to save lives and prevent further disability, we have frail older persons. There's a high increase in premature births, over 50% in Ukraine at the moment, and of course, infections that we see. And we've spoken here about climate shocks, which affect you in Lesotho as well, in fact, affect all of us. So how do people feel in their last days of life? What is it that they would like? They feel physical symptoms. They have all these social problems and worries and isolation. There's a lot of emotion that is involved. Their anger, their sadness, their acceptance eventually for some of them, and the spiritual issues, their search for meaning and connection, and the importance of religion, of culture with everybody. We need to, when we do an assessment, that is so important to find out what gives their life meaning. Who do they connect to? And of course, this picture shows you all of those emotions, doesn't it? We pain, and with pain comes anger and worry and concern. And what do they want? Well, the first thing you need to do is to ask them, what would you like when you are suffering from this incurable, life-limiting, life-threatening condition? What are your priorities? But the general ones that come out is they want their pain and symptoms controlled. It gives them dignity. It enables them to communicate with others and to maintain their quality of life. They don't want inappropriate prolongation of the dying process, but sometimes they say, I just want to live long enough to see my grandchild born, or my child, or to celebrate my daughter's wedding, or to actually celebrate a wedding anniversary, a birthday, something special. They want to maintain the sense of control and their dignity. It's not nice to have to wear a nappy and have somebody else clean you. And they worry about their family, about being a burden. And at the core of everything is, so many people say, what is most important is to strengthen my relationships with those I love and with God, however I see God to be. They want someone to be alongside them, and they want their hope to be maintained. So while in the beginning it might be hope of a cure, later on it might be hope of a peaceful death and of life after death. And so often they want to know that you'll remember them. And it's so simple to say to someone, I'll always remember your smile. I'll always remember these visits I have with you. That story you told me was wonderful. And because I work with children at Sunflower House, which is our children's hospice unit, we have a wall of remembrance. So when they say, who's going to remember me, or will you forget me? We say, no, no, your name's going to be there in the playground forever. And we put it on the sunflower wall. How am I doing for time, Esther?
Well,
I think I'm running short, aren't I? So I'm not going to go.
You're pretty much done for your presentation, but we're going to have some discussion time. But I don't know if we're actually have extra time because there is going to be time for an echo presentation. I'm not sure if Dr. Linard is part of that or not.
Okay, so what I'm going to do is you're going to get this presentation and you can go over the trajectories of dying. So I'm not going to go over that with you. You can think about the challenges you have in Lesotho. And of course, one of your main challenges is just the environment, the mountainous areas, which makes it difficult to reach. And that Tebello has told you so much about. So I won't go over that again. And I just want to say, like she did, let's celebrate palliative care in Lesotho because it is growing. And remember again the words of Nelson Mandela Madiba, a fundamental concern for others in our individual and community lives would go a long way in making the world a better place we so passionately dream of. So thank you. And lots of references, but as I say, you're going to get this presentation and you can go over it in your own time and you can check on the resources as well.
Thank you so much, Joan. That was a wonderful presentation, lots and lots of information. So it's good to know that this is recorded and we can go back over it and refresh our memories with some of the things. We do have some time for discussion right now. I'm just wondering if any of our participants has a question for Joan or a comment. One of the things that I'm just wondering is what did people think about palliative care before they saw this presentation? Has anything changed? Did anything click in your mind as you were listening to Joan's presentation? Anybody? Hello? There's somebody that would like to share? When you hear the word palliative, I know I practice in Canada and I've been to some conferences where they've actually talked about changing the name because as soon as you say palliative, people run away.
Esther, that argument's been going on as long as I've been in palliative care. Whatever you call it, it's going to be the same thing. So, but there are some departments that you will call themselves the quality of life department, the comfort care department. But at the end of the day, we need to use the term palliative care because people have got to get used to it and got to get used to using it. Mm-hmm. I don't know, George, how do you feel about that?
There is a hands up or two hands up, actually.
Okay, sure.
So maybe we can have them.
Marake, would you like to unmute your mic?
Thank you so much. I don't have a question. I just wanted to appreciate the presentations and just to say that more than anything, this presentation has just reignited my love for palliative care. A clinician, but no longer actively practicing clinical medicine. I'm in public health now, but I've always had this great love for palliative care. I think I first fell in love with palliative care as a medical student while during my rotation at the cancer hospital while at school. So really, thank you. And I think I've chatted with Tebello about this a while ago. So it's just to show appreciation. Thank you so much.
Thank
Thank
you.
you. Rosaline? Hi, Rosaline. Would you like to say something?
I'm trying.
Oh, we can hear you now.
Hello?
Hi, we can hear you.
Okay. Thank you very much for this opportunity to speak. I'm guessing this training or this introduction has opened my eyes or my mind on the fact that some people really, I didn't really think that some people do not fear death. Some people are really ready to die, even though they're ready, knowing that there are some people or the palliative care is there to take care of them, to die peacefully and to die with dignity. And hence I'm saying this is so helpful, and because it's opening my mind to understand better about not fearing death to some people.
Thank you for that comment, Rosaline. And it's true, there are people who really come to full acceptance and who don't fear death. But not everybody does. I've had patients that no matter how good the palliative care team has been, have been angry. And we have to accept that as well, because they don't want to leave their life. They don't want to lose what they've loved. So acceptance doesn't always happen. I don't know how the others would like to answer that, but I certainly have found people who fought it right till the end.
Often it's also family members who fight it to the end.
Yes.
Might not even want palliative care for their loved one because they don't want to deal with what's really happening.
And especially where children are concerned, parents.
And there's a hand that is there, Nebogang.
Thank you. I think I have a question. On the clinical area, I haven't come across a situation where, okay, we can't do away with the fact that we as healthcare providers, we have our own beliefs, our own values. And I always wonder what happens when now my patients and and their family members have the beliefs and values that are against mine, and now I have to suppress mine because now it's all about them. I always wonder how easy is it to suppress my own values and beliefs against the patients and the families. If there could be anyone to share their experience, how easy is that?
Maybe to give us a better understanding of an example of where your own belief system might be opposite to that of the patient, just to give us a bit of insight.
It's not directed to me, but in Lesotho we have people who do not believe in blood transfusion. And so if we have a patient who needs blood transfusion and and their belief is that they can't get someone's blood, but it will relieve their suffering. And now I wonder if then I should be encouraging them and advising them to take that because I believe it will relieve their suffering, or I just have to respect their own beliefs.
I recently had a situation like that, where somebody belonged to a faith that didn't believe in blood transfusions. It was an elderly person, so was caring for with general frailty of age, and she had a massive hemorrhage. And we respected her beliefs. I mean, the first thing she and her family said when it happened is, get my certificate that says no blood transfusion. And we respected that. She accepted for an ordinary infusion to be put up, but she did die eventually. But it becomes more difficult when a child is involved, because where a child is involved, we have to act in the best interest of the child. And certainly here in South Africa, you would find that the state or whoever represents the state would step in to provide the blood transfusion. But in that sort of situation, we find that we do respect an adult with full understanding who has made, because of their religious beliefs, the decision that they will not accept a blood transfusion. So I'm not sure in other countries, but that has been the situation here in South Africa. It's hard. It's very hard, but.
I like the fact that you acknowledge it is hard, because I can understand even Mev to ask that is because she has felt it emotionally challenging, especially when you know what might be the best option for the patient, but they decide otherwise. But like she also mentioned, if here in UK, because of a multidisciplinary approach that the pastoral counselor or chaplain, just to speak to them through their understanding and how they view all the unfolding story about their health, it might even change their perspective. There are times when people that have declined their blood transfusion before on my ward, they changed their mind against all their belief system that they have held for many years. So I think because of our Lesotho healthcare system, which we are all trying to really work together as we are all really sharing the experiences and the journey, to really look at the comprehensiveness of how the care can be delivered for the patients and their families. Hopefully, as we get the people on board, like pastoral care and other spiritual counselors are on board, we might be able to really shift and refer some of the cases to other people that might maybe speak from a different perspective. But at the end of the day, it's still about respecting that patient's decision. But in a case whereby we think some of the decisions, like Mayor Joan is saying, when it comes to children, there has to be another way of doing it. But in Lesotho, we still have a long way to go in terms of the legal documents that protect the minors and the vulnerables, because even adults can be vulnerable if they've got dementia, they are no longer able to make decisions, or they've got somebody has got a brain tumor and their decisions are a bit blurry. Yeah. So there has to be mental capacity assessment, but we don't have that in Lesotho. So those are a long journey to go to really see that people are protected and supported accordingly. But yeah, in a nutshell, it's just to respect people's decisions. Mema Debompana.
Thank you very much, Mayor Tebello. The presentations have been eye-openers, because sometimes we hear these things, we read about them, but sometimes it is nicer when somebody is actually talking about it and you get more points. I don't think I understood well what Mayor Joan said about euthanasia and palliative care. It is one of the dilemmas that we have always been talking about, the issue of euthanasia. And also, we talked about the patients reaching acceptance stage. How does the feelings of family members affect the patient's acceptance of the illness and dying? Because sometimes we often say, I don't know if it is in my culture, that when people close by are still hoping that the person lives, it prevents the person from dying. So I don't know. And when we have said that we should not unnecessarily prolong the life, especially when the quality of life is now poor and the patient is not recovering. So what can actually we say about the family members' feelings and relating to the acceptance stage of the patient? Can the family members' feelings prolong the life? In my culture, we say it does, but I'm just saying from experience. Thank you very much, ma'am.
I'd love to know other people's experience, but certainly I've seen cases where the family are just trying to hang on and saying, you must stay, you must drink this, you must do that. And when the family go home for the night, the patient takes the gap and dies because they haven't got people around hanging on to them. So we certainly see that the patients sometimes do try and hang in there, just take that extra treatment because of their family. And I'm only speaking from my own experience. And one of the the most complex situations that you have is so often we find a patient who has come to acceptance of their dying. They don't want to feel like this. They don't want to be bedridden and have people do all the basic toilet, hygiene for them and things like that. But the family want to hang on to them. And that's when the counseling comes in and your communication skills and trying to bring people to an understanding of each other's feelings. But I'd love to hear, Bruce, from you.
I think another question was she wanted to understand when you mentioned euthanasia and palliative care, she didn't get it clear there. Mm-hmm. And I guess it was just the information that Joan was saying. In some areas, it can be confused with euthanasia, whereas palliative care, it starts from the point of diagnosis. It is a journey. It's not just focusing towards the end of life. It starts from the point of diagnosing somebody with a life-limiting condition through their treatment journey, through the point whereby the treatment is no longer effective, and then we have to change lanes into just focusing on supportive or comfort care, through pre-bereavement or even at the end of life, and then bereavement period. So it is quite a long journey, which in Lesotho, we needed to be really get going, because more often our patients that we drop out their diagnosis as if we are running to the next flight, because we are struggling to contain our emotions. We are overwhelmed. We don't have the strategy. We don't know how to really deliver such bad news onto somebody to crush their hopes and future. And we just drop out the diagnosis anyhow. My sister-in-law in 2012, as somebody that dropped the diagnosis to her, she was only 23 years. She just told her, oh, you took your time for this biopsy to be done. What if these results have got cancer? She's just walking down the corridor and we are following her to the room. Instead of just allowing us to enter the room, she's already talking. And by the time we sat down, honestly, when it came to a point of saying, you actually have cancer, my sister-in-law crashed. And she could not even see beyond that. We tried as much as we can to give her counseling, to support her. Unfortunately, I was only in Lesotho for a couple of weeks, and that's why I pushed through the investigations for her. And even when the results said your cancer is only stage 2, so you still got many chances. It's not in the lymph nodes, so you have got a better chance, no metastasis. She just couldn't get past through the word, if it is cancer, you're gonna die. She refused all the alternative treatments, and sadly, she passed on just a couple of months down the line, 8 months. So how we deliver palliative care has to start from the diagnosis.
Mhm.
Yeah.
Communication, as Joan was saying, the important thing of our communication. I hate to close the discussion because it's so
Now, for the
good.
3 more hands.
Oh, sorry.
I don't
Tebello.
know if you can see them. Yeah.
No, I can't see all the hands. Sorry, go ahead.
Okay. Mema Tsepo.
Yes, Madam Lawyer, thank you very much. One thing I can say is that I'm a social worker myself. So I've been working with many people, and most of the time I'm working with the disability. So there's this problem where you find that, just like you said, your sister had some cancer and they couldn't accept the fact that they have cancer. Even with disability, you find that there are some people that have disability, the extreme disability, or the, I don't know if, how I can call it, but it's so extreme that you have to talk to them and make sure that the family understands very well how the disability is gonna affect whatever the expectation they have. Because most of them, we find that they'll be having this, I don't know, if it's what hope that if the person goes to some other place other than the home, they are going to be helped in a way. Yet, this disability there's nothing you can do about it. I think I had a case, it's 2-3 weeks ago, where this lady had a child who has some defects on the brain. And besides the defects on the brain, because the brain was somehow outside the head. And besides that, the child did not have they did not have the system for defecation. It was some kind of a deformation that you don't even know how to explain to the mother that this child is extremely deformed, because the mother explained that the brain is outside the head, and they don't have the anus for the patient. Also, they had one testicle that is somehow also deformed. So the mother was advised to go to leave the child to the hospital because the child was not going to live longer. But the mother couldn't leave the child because as Africans, we have something like, if he dies, then he has to die home. He has to die with me. He has to die with me, the mother, and he has to die with me. Yet there are so many deformations that already show, and the child is already a month old. And they came to my office because they felt like, in a way, the mother was like, maybe I thought the child would have gone already, but she couldn't say it in words. At the same time, they thought, the child would have gone already because the doctors told the mother that the child was going to die eventually, and it's going to happen eventually. And the child was very healthy, and there's nothing to help the child, and the child was defecating with the penis, which is very, I think it's painful, I don't know, but I thought it was very painful. But I had to talk to the mother, like some things, yes, this the thing, the euthanasia thing. Sometimes it happens and it helps a lot to relieve also the patient the pain, other than the people who are emotionally involved, because the mother said, when I asked her about how do you feel now that your child is still alive and still experiences this, she said, no, I wanted to keep the child because I thought I had some few days with the child. So I wanted to see the child throughout these days until he dies. So I don't know how to deal with this case. It's still the case in my hands right now. So can you guys help me? I don't know if you understand the case.
Tebello, do you want to answer that one? Because it is one you've been involved with. I just really like to say, I don't think it's something that we can really help you with in this short time, but we, you know, outside of this meeting, we're certainly here to give you support and advice, but it would have to be outside of the meeting because it's not something we can answer in half a minute or so. Is that okay?
Okay, yeah, I understand.
Yeah. So we'll be in touch afterwards.
But in a nutshell, the overall is still goes down to the multidisciplinary approach that Joan spoke about, because at the time of delivery and when the discharge planning was made, this should have involved other parties and stakeholders who will be involved in the care of the young mother and the child. Because the child, if the child is passing poo through the pinna, there might be even some pain. And where is the painkiller? Where is the counseling for the mother who is traumatized by seeing the child so closely deformed? Even the pre-bereavement counseling, where is it? Because if she's already anticipating the child will be dying soon, as it was mentioned, rightly so. But then what is the level of support? So all those dimensions, like Joan is saying, could be comprehensively dealt with our support and share what we think could be the best approach, and then you will see if it is applicable to your situation. But indeed, it is still the cry for Lesotho to have multidisciplinary teams dealing with the issues of this nature and complexities. I don't know if somebody else wanted to say from the faculty team.
Tebello, could I make a contribution? We thought about this situation in the last batch, and I think it left us all very moved and very affected by the plight of this girl and her baby. And I'm not surprised you are holding this in the way that you are. We feel for you. I think Joan's absolutely right. This is a situation which we can't possibly help you in the way that we would like to in such a short space of time in this forum. But as Joan has said, I do believe we can help any of you who are contributing to these, participating in these courses, that if there are these situations, please come to us through Tebello. We will do what we can. I know that you have got in country other colleagues who I'm sure would also be in a position to help. So I think we need to firm that up, don't we, Tebello, about these situations, so that we make sure that the participants feel they can, through you, connect with various faculty members who may be in a better position than I am, for instance, to advise on this sort of tragedy. I hope that's helpful.
Thank you. Thank you. Esther, I don't know if you have got some minutes. There's only one hand left before we do the echo presentation, which might not even be up to 10 minutes, just a short
Oh,
presentation.
sure. Let's do the one more hand. But I was going to say the last situation you were talking about shows how important your app is going to be. Because that would be a situation where you could use the app, right?
Thank you. And
Thank you so much. I really appreciate this presentation, and especially the part of the spiritual element that is integrated in this presentation. Unfortunately, I'm talking as a healthcare chaplain, and apparently I'm the only healthcare chaplain in the entire country. It has been difficult. It has been difficult, so much difficult that even the other multidisciplinary professions did not understand the part of the spiritual element of a patient. And having had this, somehow encourage even other hospitals and clinics and other people to realize how important it is. Because I've learned that we have so many patients who even go to the African traditional medicine doctors or medicine because it is the only place whereby they connect quality and the physique of a person and even the mental of a person. But we lack in that as the health, whereby the spiritual element of a patient is taken care of. So I think this presentation is the best ever, and I'm very excited about it. I think we are going somewhere. Thank you so much.
Thank you.
Absolutely right. Spiritual care is core and it's essential. Even with little children.
There will be a session on spiritual care as well as emotional and psychological care. Maybe we should move. Tebello, are you going to be giving us a presentation on ECHO?
Yes, indeed.
Okay.
Thank you very much indeed. This, just to acknowledge our project ECHO team at the headquarters in New Mexico in America, and the hub in India that is supporting us, including the African hub. Dr. Leonard was invited, but we believe because of many engagements, he was not able to be available. Our ECHO session, as you are aware, would be running for 8 weeks. We will be sharing videos and some information before the sessions. Whatever is relevant for that session, we will share in advance so that you can watch and read before the session. And also during the session, as you have also seen, it is about the presentation as well as the clinical case that is discussed. At this point in time, we haven't had an individual clinical case presentation because of the nature of this today's session, which is the foundation of all that will follow. But in the coming sessions, we will have case presentations whereby we will expect in some cases, especially for the coming session where we'll be talking about culturally sensitive communication, so that we will share the video and the script that will alongside that video. And if you can think about any situation at your workplace, not any of your personal cases, because it might really evoke a bit of strong emotions, which we are all emotional beings. But maybe a case at your workplace whereby maybe you were the bearer of the bad news for the family and patients, or maybe you were just witnessing the case being presented. So we can get going in that group. Otherwise, we have for this large group discussion, which we have all been sharing at this point in time. Project ECHO is the vision of one doctor who is in America, who identified such a lack of specialist. He is the liver specialist, and he realized that people were taking a year or more than 8 months before they could access him for care, at which point the illness would have advanced. And he developed this network whereby he can teach other physicians and clinicians how to take care of the patients so that they can be given care on time. So Project ECHO is all about sharing information. As the Esther rightly said, teach all and we learn all. We all have something to share, and we can impact each other's knowledge. And this is done through the technology, as you can rightly see, through this iEcho and Zoom. And B, for sharing the best practices of having didactic session, followed by the case discussion, presentation, and then general discussions, so that we can all learn and all teach. And again, it is a web-based, it's the case-based learning, just for us all to share something from our workplace or a scenario that is relevant to what we might be experiencing on a daily basis. And D is a database and monitoring of the outcomes through the iEcho platform, whereby you can see the figures of who attended, how long they attended the session, and then collected the statistics and issue certificates through that website. So the project, any organization is able to partner with them. You become the hub. Like now we are delivering this session is the Tele-Echo Hub as we are, and then you are our spokes wherever you are in your own houses. But then as you take the information and the practice to change the lives of others positively through the knowledge you have acquired, then it means you reach more people than just the telemedicine. Telemedicine would be if I am here in UK, I'm consulting somebody in another city or in another country. It's a one-to-one kind of service, which is just only impacting one person or one family at a time. But the Project ECHO has got this target of reaching millions by 2025, so that at least lives are changed and people are empowered with knowledge. As I mentioned, there's a comparison between telemedicine and Project ECHO. As you can see, Expert Hub team there, as they deliver the sessions with their expertise and knowledge, and then they impact different people, educators, nurses, doctors, chaplains, social workers, everyone involved in that teaching. It means, it means by the time you go out, you reach more people than just the traditional telemedicine that is just a one-to-one that is done remotely. So it's all teach, all learn. We created this supportive community of practice whereby we share learning, we share lessons, we encourage discussions and questions to be asked, and we actually discuss cases so we can all apply the knowledge we have acquired in our day-to-day practice. This is how it looks like, you have already seen. And we want to take this opportunity to thank our partners, Two Worlds Cancer Collaboration and PallCHASE, for making sure that they made this a start of this progress journey, attending to the needs of the people in the humanitarian settings, where people have had maybe floods, there's a war-torn zone, and other issues, humanitarian issues or earthquakes. But then they were compassionate enough to understand the heart of Starlight, that in Lesotho, in as much as we don't have war, or we don't have for floods or earthquakes, but we have got this war that is ongoing with the rising issues with life-limiting conditions, whereby we don't have well-established healthcare systems to deal and attend to the needs of the patients. And then they actually supported us in this way. So this would be the second batch. And we have got this ongoing partnership, as I mentioned earlier, with our umbrella body, African Palliative Care Association, based in Uganda, with the core base elements of information, integration, and evidence, whereby this evidence is the one that is informing the decision-making, informing the policies, so that the ongoing knowledge sharing and the integration of our palliative care in the existing healthcare programs at all levels, whether it is at a tertiary level, primary level in the community, or even at the intermediate level or at the academia, so that we can, as a country, I'm not sure if you are aware, upon all the SADC countries that are 16, it's only Lesotho whereby we don't have a countrywide, well-established palliative care programs. And that is to change with you and I. As we continue to commit and get our inner being transformed to actually see the need for palliative care and to include patients more and their families in a holistic manner, and collaborating between ourselves as practitioners, that we can really apply and really answer to these elements as they are the heartbeat of APCA. And as I mentioned, PallCHASE has been able to gather and invite different experts, as you can see, which you showed the picture earlier of more than 20 of our faculty members. We also have other colleagues and friends of Starlight who are on board, like we have got Dr. Jama Wright amongst us today. We have got other practitioners and doctors who are just willing to join as observers to see how things are done, and we are grateful. And so with the partnership, we have got Palliative Care Works, as I've mentioned. I've seen we have got Mayor Roof and Dr. George as a part of our Palliative Care Works, who are our partners for the coming face-to-face training that will be held in Lesotho when the situation allows. And we are indeed privileged because they have got such an experience in the African setting, even in the Asian setting, whereby those are the countries are predominantly labeled as a life, what do you call them? Low to middle income countries or resource limited settings, whereby you can have a little to do more for the patients with palliative care. And they have developed a palliative care toolkit, which is available online to really be able to guide us through and empower us with knowledge. And they've got this expertise in mentorship, which will be part of what will be delivered for us all in Lesotho. And we are grateful to our Ministry of Health for really endorsing this training and inviting the staff to really encourage them to subscribe and enroll into the program, as well as our Ministry of Social Development, even though they are not they are not in the document, but they have committed by inviting their practitioners from all districts, sharing the information for them to join in. So we are grateful to everyone. And as the session is, it is all going to be, as you saw it today, the facilitator will welcome everyone, and then the expert faculty of the day will deliver the topic, and then we'll have a large group discussion, which will be followed by the case presentation. After which we will have another discussion and questions, whether in a large group or in a breakout rooms, where we'll have a smaller group discussion, which sometimes will enable other people who are not confident or comfortable to express or ask in the bigger groups to be able to engage more. And then there will be a summary at the end. So I think this is just a general etiquette as we are on Zoom. Always, whenever we are able, if our bandwidth allows, to keep the video on so that we can all be engaged. But if you have got challenges with your network connection, then we understand. You can only stay on when you talk, if possible. If not, just keep the mics off while we are not communicating, so that the background noise from the house, as we are people at home at this time, so that we can just protect the privacy of your home, as well as the privacy of the community online. So just continue every time, whenever, put the questions or comments in the chat, but at the start of each session, feel free, even without being prompted, to just put your name, where you come from, and your profession, so that at least we have got an idea of who we are, because at the time will not allow us to be able to allow each one of us to introduce themselves. Otherwise, this is the IECO website, which many of you tonight will have gone through. Otherwise, we'll try our best to get the direct link wherever possible, just to try and minimize the connection issues. But whenever we can, if we can log on a couple of minutes beforehand, so we can see how it is going. So we have got these online resources, which we will share the recordings and slides accordingly. And we will also share the feedback link via the WhatsApp group, so that we can have your input, which will help us to improve. Because as we know, at a halftime, every coach that is really dedicated to his work, it is the time to restart, just to see how best to really take the team forward, encourage them, and see how best to place them. So even us, after each and every session, we would like to hear from you, your input, your suggestion, and your recommendations, so that we can deliver better each time. So there will be these recordings on the YouTube page, but we will share the recording for tonight, later on, probably tomorrow or the day after. And then let's keep the chats on the WhatsApp ongoing with any concerns you have, any of the thoughts. It is just as a peer platform, so that as we share the information, it shouldn't be one traffic conversation that is ongoing there. Share your experience, your thoughts, and your suggestion or questions. It is for us all to grow together. I think we have come to the end of this presentation. Esther, I'm grateful. And if there are any questions, we can all answer and see how we can respond. Thank you very much for everybody that until this minute.
Tebello, did you want to take a picture of everybody in the class? Do you usually do that in your first one?
Well, let me do that now.
If everyone puts on their camera.
Be ready? Okay. Okay. If you can, please. Yeah.
Are you taking it?
Another one? Yeah. I'm taking the last page.
Great.
Yeah, I think we have done well.
Thanks, Tebello. So for everybody, also the link is in the chat right now. And I think you've given us a little bit of fire in the belly. Thank you very much. We look forward to seeing everyone for next time for the culturally sensitivity communication and palliative care.
Dr. George would like to say a word before we go, just in preparation for next week, please.
Yeah, thank you very much indeed. Thanks, Tebello. Just to say, touching on what Tebello has said about the group work, we really want to hear from the participants, from you all, and we're going to be talking next week about communication skills and culturally aware aspects of death and dying. And clearly this is a very difficult area for us all. And we're going to include a presentation around possible ways in which you might break bad news. And in order to learn from each other, we'd really appreciate it if you brought, as Tebello said, the situation from your own workplace. Now, because these are sensitive areas, we'd like to reassure all of you who would like to bring presentations or experiences from your workplace that this will be done in smaller groups. So in this, my colleague and I will give a short presentation on communication skills, including models of how you might break bad news. Then there will be a short questions and answer session with the big group. And then we're going to put you into smaller groups, each of which will be led by faculty members. And in advance, I'm really grateful to faculty members for doing this. So it will help you feel safer and more private to, perhaps in groups of 5 or 6, to share some of those experiences and talk about them and how they leave you feeling and what went well and why did it go well, what might not have got well and why didn't it. So just looking at how it was for you, because this is what it's all about, is helping us all learn from each other and from these experiences. So I'm looking forward very much to seeing you all next week with my colleague Gillian Chans and Ruth Woolridge. And thank you again, Tebello, and it's great to be amongst you all again. Thank you.
Thank you. If no one else has another comment, then we'll say goodbye and see you next week.
Thank you.
Hi, everybody.
Thank you.